Hello, this is a case I had to do cataract surgery on a few days ago, and it was particularly difficult because it was a lady with angle closure glaucoma, and she had uveitis, posterior synechia, and corneal neovascularization. The biggest problem, although, was that the anterior chamber was very shallow. It was less than 1 millimeter. So I was thinking about doing a blind vitrectomy just to be able to get the anterior chamber depth within expected limits. I placed a trocar in the inferior part. Of course, I have to emphasize it's very important to do a B scan before the surgery to be sure that the retina is attached. Then I proceeded to do my first side port incision. You can see that there's iris drag, and that is because the anterior chamber is very shallow. I tried to insert viscoelastic, but I could not get the chamber to deepen. Sometimes if the vitreous is liquefied, it's not always needed to do a vitrectomy, and the liquefied vitreous can escape the trocar. This was not really the case, so I did just within the port vitrectomy, and you always have to be cautious. Just do a few seconds, and then just check if the pressure is low. Then you can typically add, as I did, viscoelastic, and you would be able to get the chamber deep enough. I was lucky enough that the synechia broke just with visco dissection, and I placed some viscous on the cornea. Afterwards, I proceeded with my second side port, which was a lot easier as there was no tissue drag. And then closing the valve trocar. And performing the main incision. Skipping ahead, after I removed the viscoelastic, I placed an air bubble and then used trypan blue to stain the anterior capsule. I like to use it as a brush just to get more contact with the anterior capsule and then get a better staining. Washing away the excess trypan with BSS. And then filling the anterior chamber again with viscoelastic. And proceeding with the Capsulorhexis. In these cases, I like to aim a little bit small in the beginning, as you expect sometimes things not to go so smoothly, so you will have a good support if you would like to do an optic capture and place the haptics in the sulcus. It can always be enlarged further in the final steps of the surgery if it's needed. Now the pressure was not okay, so I stopped to add some viscoelastic. This can always be done, and this keeps the procedure safe, as there is high pressure within the lens. Sometimes a good idea is to aspirate the liquefied cortex. It was not the case here, and Rexis went fairly easily. proceeding with hydrodissection. And then phaco-emulsification. My preferred technique for this hard lenses is to do a phaco chop. So I'm just aspirating the anterior cortex and then impaling the phaco tip and breaking the first piece. Aspirating it. It is all in real time. It's not being speeded, accelerated, just to be on the teaching side. But phaco-emulsification went fairly smoothly. Always before removing the phaco tip, in this kind of cases when we expect back pressure, it's a good idea to fill the anterior chamber with scholastics. And then proceeding with irrigation aspiration. Quite thick cortex there, but it was possible to get it out with IA. The rest is a question of getting the residual cortex and polishing the anterior capsule, so I will speed things up in the interest of time. After irrigation aspiration, I am placing viscoelastic again in the anterior chamber. And then using a capsular tension ring. There are multiple ways in which this can be achieved. My preferred technique is using a bimanual approach. I think it provides more control and stability. And now using a hook just to dial the CTR in the bag. Afterwards, proceeding with IOL implantation. We're using a C-loop hydrophobic lens for this case. acrylic. This is my preferred lens for patients that had previous intraocular inflammation. We will proceed in enlarging the Capsulorhexis. I'm using a Vanas forceps. And then the Vanas scissors, and now the forceps just to enlarge the rhexis. In this step I like to hydrate my main incision, as I will not be using it anymore. And then using irrigation aspiration to remove the viscous from in front of the lens and behind the lens always. I will speed this up just in the interest of time. Performing hydrosutures on sideboards. And then placing an air bubble in the AC just to avoid any IOP spikes in the first day. Making sure that the pressure is okay. And then just removing the trocar. And doing a dexamethasone injection under the conch. Thank you. And this is the end of the surgery.